Hello, everyone. Welcome to today's live broadcast towards a neuroscience of bipolar disorder risk. I am Judy O'Rourke of LabRoots, and I'll be your moderator for today's event. We have a few important announcements before we begin. This presentation has been approved for a Category 1 continuing medical education credit by Loma Linda University. If you are interested in obtaining CMEs after attending this presentation, please click on the Get Your Free CME CE Credits button in the bottom left corner of the event screen. This webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you have any technical problems viewing or hearing this presentation, please click on the support button at the top right of your presentation window or submit your problem through the green Q&A button lower left. I would now like to introduce today's speaker, Dr. Philip Mitchell. Dr. Mitchell is Scientia Professor and Head of the School of Psychiatry at University of New South Wales in Sydney, Australia. Member Australian National Health and Medical Research Council Research Committee, Vice President Governance, International Society for Bipolar Disorders, and board member, Black Dog Institute. His research and clinical interests are in bipolar disorder and depression, with a particular focus on predictors of the development of bipolar disorder in at-risk individuals, molecular genetics of bipolar disorder, pharmacological and psychological treatments for bipolar disorder and depression, clinical phenomenology of bipolar disorder and depression, and neurostimulatory therapies for depression. Professor Mitchell has published over 450 peer-reviewed papers or book chapters and is lead investigator on an Australian NHMRC-funded program grant on depression and bipolar disorder. He serves on the editorial boards of Psychiatric Genetics, CNS Drugs, CNS Spectrums, Frontiers in Behavioural and Psychiatric Genetics, Future Neurology, International Journal of Bipolar Disorders, Medicine Today, and Therapeutic Advances in Psychopharmacology. I will now turn it over to Dr. Mitchell for his presentation.
And welcome this morning. I've decided today to pick the topic of towards a neuroscience of bipolar disorder risk. We usually think of neuroscience for established disorders, but increasingly we're looking at illness before it becomes fully developed. I think we're starting to think about that in psychiatry with respect to schizophrenia, but there's a developing literature on risk to bipolar disorder. I think the reason that I'm attracted to this area is that this really does have substantial potential clinical relevance. Before we start, just to indicate my disclosure of interest, I've not had any financial linkage with pharmaceutical industry for over 5 years. The work that I'm going to be describing is very much a collaborative exercise between my institution here in Sydney, Australia, University of New South Wales, and Black Dog Institute, and I list here a number of the team members, colleagues in Brisbane, in Queensland, colleagues in Neuroscience in Sydney, and also an ongoing collaboration with a number of colleagues in the US through a NIMH-funded multi-site bipolar disorder high-risk study, and I've listed those colleagues there. A number of the papers that I'll be reporting on are joint studies with my US colleagues. We're increasingly thinking of bipolar disorder in terms of stages. This was a very recent article published by Ellen Frank and David Kupfer in the journal Molecular Psychiatry in the last month or two. And this talks about the various stages of bipolar disorder. Clinically, we've historically thought of bipolar disorder as the presentation that we see at a particular moment in time. As well as being a researcher, I'm a clinician, and treat people during manic or depressed phases. But now we're increasingly looking at the lifetime or longitudinal perspective. And what I want to do here is to focus on the pre-illness phases of bipolar disorder. So if we look at the next slide, we can see that, and this is a table from that article by Ellen Frank and David Kupfer, that 4 stages of bipolar disorder are listed here. I'm going to be focusing on phases 0, 1A and 1B. And I think it's worthwhile just looking at what this means. 0 is where there's increased risk, and in general this is defined as heightened genetic risk because bipolar is a very strongly inherited disorder. 70 to 80% of the cause of bipolar is genetic. Phase 1A is where the individual starts to have mild or non-specific symptoms. And phase 1B is really just a variation of that the symptoms are becoming more significant and there may be some functional decline or neurocognitive changes. So phase 2 is when the first episode presents, and in general we're thinking here of a clear manic or hypomanic episode that's defining that the person has bipolar. In this presentation, I'm going to look at our work and the work of others around the world that are really starting to try to elucidate what phases 0, 1A and 1B comprise. This was an article, editorial, that we wrote a few years ago in the journal Neuropsychiatry. This is with colleagues Gloria Roberts and Melissa Green. And the topic here really, I think, indicates the reason that we're doing this research. It's not just esoteric looking at the clinical and biological features of people at risk to bipolar. As I said to you before, that I'm also a clinician as well as a researcher. And really, this work, I think there's excellent chance that this will assist in future early intervention studies and future prevention. The early intervention is more realistic. In schizophrenia, we've already started to institute early intervention, but in bipolar, that's not really been possible because we don't have a clear prodrome as exists for schizophrenia. I guess to flesh out a little bit more about the reason for this study. Now, the picture on the right, I think, epitomizes the importance of this research. This was a photograph from an article we did for a major Australian newspaper. And the man in the middle, Jamie, and he's been very public that he has bipolar, has had the anxiety or concern about will his children, and his 2 daughters are to either side of him, and his anxiety is, will one of those daughters develop bipolar? And if they do, can it be picked up early, or can it even be prevented? So it's really from human stories like this that this research originates from myself and others around the world to stop the disability of people like Jamie there. The poignancy or sadness of that picture is that Jamie's brother, who also had bipolar, suicided about 6 months after that photograph was taken. And I think that highlights the tragedy when this illness isn't well controlled and the importance of being able to prevent or to intervene early. So in this research, the first bullet point is we want to be able to identify those factors that determine which kids, which children of those with bipolar or siblings will develop it, and also interestingly, who will be resilient, because I think the resilience to these conditions is just as important. And as I said, that this is hopefully will aid future early intervention and prevention studies. Well, how many people who are at risk go on to develop bipolar? I think the best way to, demonstrate that is this slide from a very important and large Dutch study. This was published in the American Journal of Psychiatry in 2013. And you can see to the left, these are the baseline assessments that were undertaken in 1997. And you see down the bottom that 79 people at that stage had no diagnosis. Up the top in the red, 4 had some form of bipolar disorder. And you can see over the years as they followed people up after 1 year, after 5 years and after 12 years, that an increasing number of people transitioned through various conditions. So you can see by the 12-year follow-up, 17 of that original group, and the original total cohort was 140. So just over 10%, about 11% after 12 years, had developed some form of bipolar disorder. But it's interesting that you see here that it's not just bipolar disorder. We tend to think of the inheritance of this condition as being bipolar disorder or unipolar depression. Certainly, a considerable number of people are developing those two disorders. So you see over 12 years, as well as the 17 who've developed some sort of bipolar, 51 have developed some sort of unipolar. That's mainly major depression, recurrent or single episode. But it's not just that. There's also anxiety disorders and other disorders, and we'll explore that in the presentation, because one of the emerging consistent strands in this research is that people at risk for bipolar are also presenting with a higher risk of other conditions as well as bipolar. And it's also interesting, you see that there's a transition or evolution over time to bipolar, that very few go direct to developing bipolar from no diagnosis. A few do, but most transition through other conditions. And I want to come back to that theme as we go through the presentation. Now you might be wondering about some of the pictures to the right, and some of these are famous individuals who have or may have bipolar. So to the right here we see Carrie Fisher from the photograph from Star Wars. Now there are a relatively small number of high-risk studies that are following people longitudinally around the world that are using biological markers. I already referred earlier to my collaborators in the US multi-site study, who are doing clinical and genetic studies. Our studies, which, as you will see, we're looking at clinical assessments, genetic assessments, structural and functional brain imaging, as well as neuropsychological studies. In the next slide, you can see some of the other groups. The picture on the right is a very old English comedy group. Some of you might be aware of the Goons, and Spike Milligan on the left, very famous English comedian who had bipolar. There's a Canadian group with Anne Duffy, Paul Groff, Scottish group Andrew McIntosh, a Swiss group, and there are a number of others who have just started or are about to embark upon these studies. So we're seeing that this is, at the moment, a relatively nascent area of research, some very important research starting to emerge, but an area where you'll see many more groups over the next few years. The whole issue of the capacity to intervene early, I think, is really so important. The picture to the right there is an Australian artist, young man who was manic, and this portrays his experience of mania. And sometimes you'll see some artistic pictures. There's an Australian publication of art by patients with various conditions. We are collaborating with the US group, and when I talk about studies emerging from our collaboration, and I'll be talking about studies coming out of our own group individually, plus our collaborative group, that between our two groups we've now accumulated a sample of 367 at-risk young people who have a first-degree relative with bipolar disorder, and 229 controls. So you can see that there's a substantial sample being accumulated and recruited. This is the publicity we've used for our study, and I put that up because I think it gives you a feel of why we're doing this research and the benefits. And the reason that we find that patients and their families are attracted to being involved in this research, as well as being at University of New South Wales, I work in a specialised depression bipolar institute called Black Dog Institute that comes from the old English term for depression, the black dog of depression, that was made well known by Winston Churchill, the UK wartime Prime Minister, and his famous V for Victory sign. So down the bottom there you can see the logo of Black Dog Institute is Churchill's V for Victory, and the symbol here is you can have victory over depression. But if you look at the shadow, it's the shadow of the black dog, not just the shadow of the fingers there, the V for Victory. And the symbolism here is that you can have victory over depression, but the black dog of depression still shadows you. It's in the background and could potentially re-emerge. But the graphic for the study, when I discussed it with our graphic artist, he portrayed it in these terms of catch them before they fall, so that the potential benefit of this research is we can identify people who are at high risk, institute in future studies treatments that will reduce the likelihood of emergence, or at least catch it early before it becomes profound and disabling. And I think this nurturing image of the young person with this outstretched, comforting hand, I think really epitomises what this research is on about around the world. So the specific aims of this research, and I think that this would also speak for other groups that are doing the same sort of work, is the first is to, at the moment, as you'll see, we've embarked upon a longitudinal study, but the work that I'll be presenting is our baseline assessment. So even at baseline, when we first identify someone who has a high risk of this condition, so we'd be thinking clinically of a patient who comes into our office who has a parent or a sibling with bipolar. Can we identify any differences at that stage when we're doing brain imaging, genetic studies, or neuropsychological assessments? The term endophenotypes is a difference that exists that is separate to the clinical manifestation of the disorder, and the theory there is this may link closer to the genetic origins of the condition. Ultimately, what we're wanting to do is to be able to identify which of these young people will actually convert or develop bipolar. As we saw in that Dutch study, we know that about somewhere between 10 and 15% of these young people will go on to develop bipolar. So the capacity here of this sort of work is to, in a more fine-tuned way, focus down to which of these young people will actually develop bipolar. We know they're all at high risk, but how do we identify more closely that 10 or 15% who will develop the condition? So as this research develops, we want to be able to see which imaging, clinical, genetic changes predict more accurately who will convert to bipolar. So this is a flow chart of where we're up to at the moment, and I don't want you to get too caught up in the figures, but you can see that our first group are now entering the 5-year follow-up. There's ongoing recruitment, so it's hard to get a good feel for numbers involved, but we've retaining about 85% in this study. This work involves screening a very large number of individuals, so you can see at the top of the right-hand side, we've screened well over 1,000 individuals. Now we have 3 groups. We have the high at-risk group, which is children or young people, and they're all between 12 and 30 because that's the age at which this condition starts to present. So they all have a first-degree relative parent, mostly some have siblings. That's why we call it the kids and sib study. So there's 173 at risk. We have 131 who are controls, and these come from families with no evidence of mental illness, and also 69 individuals in the same age group with bipolar. So that will allow us, if we find changes, to be able to say, are these changes the same as you see in someone with established bipolar disorder? You can see on the left-hand side, we do a detailed assessment with clinical interviews. We do genetic studies, series of brain imaging studies, and neuropsychological testing. So they come to our research unit in Sydney for a whole day, and then we follow them up on an annual basis. But I'm only going to present the baseline findings today. But you can see it's a large study. We have almost 400 individuals here in Sydney, let alone those that we're involved in our collaborative studies in the US. I'd like to first start off with our clinical findings. And for those of you who are interested in pursuing this further, these have just been published in the last month in the Journal of Psychiatric Research in this paper with Tanya Perick, one of my research staff, as the first author. And I really want to just draw out some of the central findings here and comment about how these reflect work going on around the world. So the first finding that emerges from this work is the very high rates of psychopathology or psychiatric disorders in the high-risk group. And I'd draw your attention, because it's a busy slide, this one, but the column with the red results there. So that's the at-risk group. That's this particular report. This was the first 118 that we assessed. We've done very thorough diagnostic assessment using the best estimate methodology with a trained researcher doing the interview of both the parent and the child, then two independent clinical researchers looking at the interviews and coming to a consensus about the diagnosis. So I've got confidence the diagnostic procedure has been robust. If you look at the top row here, any lifetime affective disorder, you can see that almost 30%, 29.7% of the at-risk kids have an affective disorder. And this is predominantly single or multiple major depressive episodes. The controls, just to the right there, the rate is 12.7%, and that's what you'd expect from studies of a largely adolescent and 20s age group. And the bipolar group, obviously, because they all had bipolar, 100%. But you can see here that there's a clearly much higher rate of depression occurring in the at-risk group. I should say that we allowed any condition apart from bipolar disorder in this particular analysis. So you can see these are kids that are having a high rate of depression. At one level, that's not surprising. Go to the next line. You see there's a high rate of anxiety disorders in this group, 22.9% compared to 10% of controls. There's a high rate of behavioural disorders, just over 9% in these young people. And when you go down further, you can see that those that having at least one lifetime condition, 53.4%, and two or more conditions, 17.8%. So you can see these are kids, they have not yet developed bipolar, but they have high rates of psychiatric illness. So they already are suffering a burden of psychiatric conditions. Now, another way of looking at this is to look at the relative risk, or the odds ratios, and this gives us an idea of how much the increase in rate of conditions we see in that risk group. You see in the red here is the at-risk group. Here the controls are referenced at 1. So you can see for any mood disorder, which is mainly depression, that there's 2.6 times the risk of developing depression in the at-risk group, 2.7 times for an anxiety disorder. They're both significant. A trend towards higher rates of behavioural disorders, and you can see here 3.2 times the risk of having at least 2 disorders. And you see at the right that people with bipolar are heavily burdened with lifetime risks of anxiety and behavioural problems, as well as substance use. So I guess the take-home message here is that young people at risk of bipolar are already suffering a very high burden of psychiatric disorders. If we look at this graphically, we can see here, and this is a survival analysis chart, looking here at the onset of mood disorders. So in the controls in the light green dotted line, this is the population rate of depression. You look at the blue line here. This is the rate of depression occurring in our sample. This is retrospective data from both the parent and the child, and then the bipolar group in the red. And you can see that they all develop a mood disorder by definition. So by the age of 30, they've all developed bipolar. But what we see here, very interestingly, and our group's the first to be able to demonstrate this because no other studies have had the control group, the at-risk group, and the bipolar group in the one study, that you can see that the rate of development of illness as well as the magnitude of the amount of illness is intermediate between the controls and the bipolar group. And this is what you'd expect because some of these individuals will go on to develop bipolar, some won't. So it's very interesting to see that these intermediate rates of depression in this particular sample. And when we look at using these same groups, looking at anxiety disorders, we can see at the top the population rate of the development of anxiety disorders over time. Down the bottom, the high rate of anxiety disorders you see in the bipolar group in the red. And then again, the intermediate rate of anxiety disorders. So this is a group that's already developing anxiety disorders, and we'll look at the significance of that in a minute. But again, intermediate between the bipolar and the control sample. So very interesting figures. Again, emphasising the burden, but also, that this is occurring reasonably early in people's lives. Now, how does this compare with other groups? So my collaborator, John Nernberger, in Indianapolis, published this report in the Archives of General Psychiatry in 2011. And I'll just pull out one of the critical figures here. And it's a little bit complex, but you can look at this later at your leisure. But essentially, what he showed was that individuals who go on to develop depression or bipolar are clearly having higher prior rates of anxiety disorders and behavioural disorders. So in in table A at the top, that the group with major affective disorders have higher rates of prior anxiety disorders, and down the bottom, compared to the controls in green, higher rates of behavioural disorders. The other group that has published figures on this is Anne Duffy's group from Canada, and she's published a number of reports which I'd encourage you to read. And she's also looked at this issue of prior conditions before the bipolar or severe depression develop. And this is a graphic from her 2010 paper. And you can see here that if you have a lifetime anxiety disorder, it's a little different way of looking at the same question. So in the red, if you have a prior anxiety disorder, you have a higher risk of developing severe depression or bipolar. And I should say in the Nernberger study that this didn't happen in the control group. This was only happening in the at-risk sample. So here are two studies indicating that if you have an anxiety disorder, or in the Nernberger case also a behavioural disorder, you have a higher risk of developing depression or bipolar. Now, when we looked at that in our own sample, we found that when we looked at our at-risk group alone, it wasn't clear, but when we combined our at-risk and bipolar groups using the same methodology, that prior anxiety disorders increase the risk and the earlier onset of severe depression or bipolar. So in this graphic here, again, a survival chart, if you have the dotted blue line, which is no prior anxiety disorder, and here this is prior, this is not lifetime, prior anxiety disorder in the red, you've got a much higher likelihood of developing either severe depression or bipolar. So this was a partial replication of the other groups, and interestingly, we also found this when we looked at behavioural disorders. So we see here that prior behavioural disorders in the red, there was a higher rate of the likelihood of depression or bipolar. And I think these figures start to make us think about when we're looking at, what does, the available information tell us about the potential for early intervention. It's suggesting that if a person who has a first-degree relative with bipolar and they have either a prior anxiety, either have a current anxiety disorder or a behavioural disorder, this is a young person who is already at higher risk than the other bipolar at-risk people for developing this condition. So perhaps one of the things we could start to focus on, as clinically as well as research, is young people with a family history who already have a clear anxiety or behavioural condition. We might want to come back to that in the question and answer. So Anne Duffy has presented this schematic, which I think is very useful. So what she's proposing, and this derives from the schizophrenia literature of an evolution or transition in people who are genetically at risk. And you can see up the top here, she's proposing that people don't transition directly from wellness to developing manic or hypomanic episodes, that they go through this staging sequence. And that's how we started off this presentation of looking at the theoretical model of staging, that people go through non-mood disorders, and that, as we've seen, can be anxiety disorders or behavioural disorders, through to minor mood disturbance, through to depression, through to mania, and that substance use may be a catalyst for triggering the final development of mania. So I think this evolution or transition or staging model, I think, is very useful and really underlies conceptually a lot of the work that we're talking about today. I now want to move on to some of our studies of neuropsychological genetic and imaging. Some of this has been published, some of this has been submitted for publication, but I think it's very interesting in terms of helping us to understand what is the status of a young person who is at high genetic risk for bipolar. So if we look at neuropsychological functioning, there haven't been many studies that have looked at this. Probably the main literature comes from looking at family members of individuals with bipolar disorder. And those studies suggest problems in working memory, attention, and maybe social cognitive deficits as sort of endophenotypes. I mean, we talked about that before, intermediate markers. So the literature would suggest that people who in the families of people with bipolar have these neuropsychological deficits. Now, the difficulty is many of these prior studies were in older individuals. The average age in the 40s. So in our work and that of others, remember we're looking here at, in our particular study, 12 to 30-year-olds. So our average age is in the early to mid-20s. So it's a much younger population. And also we've been looking at individuals with bipolar to compare them. So for this particular report, we looked at 16 to 30-year-olds. We looked at just Caucasian individuals, so we didn't have issues of different ethnic findings. So in this particular study, we had just under 100 young people at risk to bipolar. None of them have yet developed bipolar. Here's 78 healthy controls and 52 with a confirmed diagnosis of bipolar. So these numbers, in terms of the at-risk, this is one of the biggest samples that's been done, even when you look at studies that have looked at older individuals in families of people with bipolar. So what did we find? We found subtle but definite changes in our at-risk sample. They showed some deficits in verbal intelligence and affective inhibition, so their ability to switch on or off responses to affective stimuli, and these were faces with strong emotions. But the critical issue here is the subtle impairment of verbal intelligence. When we looked at our bipolar individuals, we started to see more significant and apparent deficits. So they had problems in attention. Remember, all our patients here are 30 or less, so this is a relatively young population. But we didn't find widespread change, as has been reported in some of the older individuals with bipolar, and most of those have an average of patients being in their 40s. So you can see there wasn't a widespread cognitive difficulty. When we looked at our bipolar individuals and looked at those with bipolar 1, and for those of you not familiar, that's individuals who've had clear manic episodes, we saw more profound difference in those than the bipolar 2 individuals, they're people who've just had hypomanic episodes. And you can see here there were significant executive deficits in our bipolar 1 individuals in terms of attentional and immediate memory tasks. We also found some abnormalities in social cognitive. This is the ability to respond to and understand emotional portrayal in faces or in scenarios. But I want to focus here particularly on the cognitive functioning. So you can see here that the main abnormalities were in our bipolar 1 individual. So how do we draw all that together? We found subtle but not widespread differences or deficits in the young people who had risk for bipolar but not yet affected. So we were seeing some differences, although they were subtle. In those with bipolar, we saw selected impaired executive functioning. But I think the third point here is that the extent of impairment in both groups was less pronounced than those that had been described in older samples. So how do we sort of make sense of this? I think what it's showing us is that while there are some changes occurring, subtle in the high-risk people, they're not as profound as you see in patients with who've had illness for years and it's more established. So I think that there's some what we call illness progression changes occurring here. So neuroprogression is the terminology that's been used. So perhaps that the cognitive changes we see in older people with bipolar are a reflection of illness progression, and that they're there only subtly, either prior to or in the early stages of illness. And to me that gives me optimism that if you treat illness well, or perhaps develop techniques for focusing on these cognitive deficits, that perhaps we can remediate or minimise the impairments that we see in older individuals with bipolar. Perhaps we might want to pick that up in the discussion, but I think these are very important findings in terms of targets for future studies. I'd now like to move to some of our biological work, and I won't spend an enormous amount of time, but I want to highlight some of the findings that are emerging from this. The rationale for the genetic study is, can we identify whether there's a greater burden of bipolar risk genes in these individuals? Now, intuitively you'd expect that, but no one's really formally looked at this question before. And when we look to the future, one of the issues when we're looking at people at risk for bipolar, is a high burden of risk genes one of those factors that will determine who goes on to develop the full-blown bipolar illness? I think these are very important and critical questions. So for this study, we used combined data from the US and Australian samples, and as I've said before, we got well over 300 at-risk individuals and over 200 controls. And these are individuals all with a high risk of bipolar. What we've drawn from is the very important study that was published in 2011 that identified risk genes. This study identified a number of genes that were statistically significant in a very big bipolar sample compared to a very large control sample, numbering in terms of thousands. And for that particular study, they identified the top 34 genetic markers and then tested those in a replication sample. So when I talk about us looking at 34 markers, it really comes from this 34 markers that are identified as the top hits, genetic hits, in that very important paper in Nature Genetics a few years ago. Now, we looked at these top 34 genes, and this is a bit complex, and I'll just tell you the simple story here. So you can see these are these three graphs are different ways of looking at the genetic findings. Now, the important issues here are that those who are at risk are the black bars, the controls are the white or empty bars. The figure down the bottom is the number of risk genes you have. So if you just focus on the white bars at the beginning, this is the normal population. So this is, you and me. What it's saying is that we all have variable number of risk genes for bipolar. So you can see the distribution there in the white. Some have a small number, some are peaking, and then some have a large number. The peak in the middle there, the average. But what's striking here is you see that with the black bars for each of these, that it's shifted towards the right. That those who are at risk with the black bars are at each point. You can see that as it moves to the right, that the individuals with the black bars have higher proportion or burden of these risk genes. And I think the point here is, and this is statistically different, that people at risk for bipolar have exactly the same genetic risk genes we all have, but they have a higher burden of these particular bipolar genes. So we all have some of them, but individuals at risk to bipolar have more of them. And I think this is indicating that to get bipolar, you need an accumulation of a large number of risk genes. And this top 34 is only the top 34, and undoubtedly there are many more risk genes that are going to be identified. I won't go through this. This is the statistics, and you see down the bottom when we only looked at the European individuals or the Caucasians, that we saw using these different analyses a higher burden of these risk genes in the bipolar in the at-risk sample. It's subtle differences, but significant. Some of you in the audience may be familiar with receiver operating characteristic or ROC curves. Many of you won't be, but this is a way of looking at how valuable this is in terms of diagnosis. I think it's fair to say at the moment this is not at the point where it would be diagnostically useful, but you can see there's a statistical difference in the when we look at the sensitivity and specificity comparing the at-risk and control. So I suppose the take-home message is at this stage not diagnostically helpful, but indicating a statistical difference. I'll very rapidly take you through some of our brain imaging findings because I want to leave time for at least 10 minutes discussion in our presentation today. Now with the imaging, we've done functional and structural imaging, and I'll take you through some of the work that we've published as well as some of that we've submitted for publication. Now, our first imaging paper appeared in Biological Psychiatry 2 years ago, that you can look at that at your leisure. This was a functional imaging study, and the basic premise here was that we hypothesized that individuals at risk for bipolar may have difficulties in regulating or responding to emotional stimuli. So we gave them a task, as we see in this slide, and again I'm not going to go into the detail, where people were in the MRI scanner. They looked at a computer screen with a series of facial images with various emotional expression, and they were asked to either respond or inhibit response to these various emotions. And we know that this particular task activates in normal individuals areas of the brain related to emotional control. And what we found was a very striking finding, and this, in simple terms, we didn't focus on a particular area. We looked at the whole brain and looked at differences in response between the individuals at high risk compared to the controls. And one area stood out. It was so striking that when I first saw these results, I thought something was wrong. We've made some mistake. So we checked through this, and certainly it wasn't artifactual. And this is in an area deep in the brain involved in emotional regulation and experience called the inferior frontal gyrus, or IFG. And this was less activated in those at risk, less activated in those at risk compared to controls. Very highly significant to controlling for all areas of the brain and also controlling for mood and medications. And what this indicated to us is that there was an attenuated response, that there was an insufficient brain activation in this area. Although individuals could complete the task adequately, the brain activation was reduced, indicating that there were deficits in brain neural response to this emotional recognition task. This fitted in with studies that have been coming out in those with bipolar. This is a meta-analysis of fMRI studies that was published a few years ago, and this showed that attenuated activation of this IFG region is a consistent abnormality reported. So this gave us some confidence that perhaps we were identifying in our at-risk individuals this propensity for lesser activation of the IFG that is already being seen in individuals with well-established bipolar, suggesting that this may be a vulnerability marker for bipolar. That needs to be confirmed. I suppose another study, which is an example of others that gave us confidence of the validity, was a study from Ellen Liebenluft's group from the National Institute of Mental Health. And you can see here in this report in bipolar disorders last year, using a different task, again finding reduced activation in this inferior frontal gyrus or IFG region. So some consistency in these findings. I'll very quickly move through some of our structural studies. This was a report from the Canadian group that have found abnormalities in the volume of the inferior frontal gyrus in the Canadian and Czech samples. Here, this is volume, this isn't function. They found a larger volume, again highlighting this IFG region as an area of interest. I won't go, because of time, moving on into detail with our own structural work, but we are finding definite, statistically significant but subtle abnormalities in the parahippocampus, and then to the right, the pars orbitalis. Now, probably an area you're not familiar with, but this is the area overlying the inferior frontal gyrus. And again, this is in our own sample. This is a reduced thickness of the cortex over this area. Again, consistent with our findings, suggesting abnormalities in this region. We've also used a different analysis of brain structure. I won't go into that, again suggesting subtle differences. I just want to spend a little bit of time, then we'll move on to question and answer about brain connectivity, a very hot and cutting-edge area of science. This was the cover of the journal Science a few years ago, emphasizing the importance of the emergence of the capacity to study brain connectivity, both functionally and structurally. Carl Friston, a very eminent researcher in the field, talking about structural, functional and affective connectivity. And I'll just quickly move through some of our findings. I'll have to move quickly through some slides, but we looked firstly at the question of, was our inferior frontal gyrus finding an abnormality per se of that area, or a reflection of the various network inputs into that area? This is somewhat complex statistics, but we looked at the interplay of the various inputs to this IFG finding, the facial recognition, the inhibition through the prefrontal cortex, and the fear response. And the take-home message is that there were differences in the inputs between the healthy controls on the left. So the pattern of inputs determining the final IFG result were different in terms of the networks impinging on that. So you can read through this later, but a very important finding. Just in terms of some other functional work that we've been doing, and this has been recently submitted, we've looked at the functional connections to this IFG region and found differences in the strength of these functional connections with other areas of the brain, particularly those involved in emotion. And again, I'm sorry, we've got to move through this quickly. This has been submitted and will hopefully be available in published form in the not too distant future. The main reduction in functional connections being in the bipolar group, then the at-risk group compared to the control. So again, we find this result of intermediate differences in the at-risk group compared to the bipolars. And these are expanding upon that. Again, I'm sorry for having to move quickly through these. And we found very similar results. This is very preliminary work when we looked at the whole brain, not just seeding to this IFG region. In terms of structural connectivity, we're finding intriguingly, this is with just straight MRI, differences in the corpus callosum. This is one of the emerging findings coming out of the bipolar literature. So we're already seeing in the at-risk group differences in, so this is DTI in terms of fractional anisotropy. Again, intermediate findings in the at-risk group reflecting impairment in the pathways passing through the corpus callosum. Some of you might be aware that this is now being replicated in bipolar individuals, and here we are finding this. This was a report from JAM Psychiatry recently, and we're finding this in the at-risk group as well. Other groups like Andrew McIntosh's group from Edinburgh have also reported abnormalities in FA in these at-risk individuals. So again, very exciting emerging repeated findings of differences in brain structure and functioning even prior to the bipolar developing. The other way of looking at DTI is what's called probabilistic tractography. These allow you to have these lovely images of the elegance of pathways in the brain. This is one of our at-risk individuals. You can see the various pathways coloured here. And without going into detail, we're finding in our early analyses impaired, reduced pathway strength when we look at this other way of analysing DTI scans. Others, like the McIntosh group, are already looking at the capacity of imaging to predict future clinical status, and we'll be able to do that in the near future. So really just to draw all this together to allow us a few minutes question, this very exciting stage of trying to identify the neuroscience of those at risk to illness. At the moment, our own results and most of those around the world are cross-sectional. As you saw from the last few slides, we're now starting to see the emergence of predictive capacity of these studies to indicate those who'll develop later depression or bipolar. But at the moment, in our own work and those around the world, we're finding in the at-risk sample higher rates of depression and anxiety and also behavioural disorders, and these are intermediate between the controls and bipolars. We're finding evidence of a higher rate of bipolar risk genes in this sample and early but repeated evidence of brain imaging differences in this group. So a very exciting stage, and I think there's a very good likelihood in the future that this will be able to facilitate early intervention when we look at these various assessments assisting us in identifying those who are at particular high risk for developing bipolar. These are the institutions that I work at, the University of New South Wales on the left and the Black Dog Institute on the right. And I'll hand over back to Judy to chair the question and answer session. So Judy, I'll hand over to you at this stage. Thank you.
Thank you for that informative presentation. Before we get started on the question and answer session, I'd like to remind the audience how to submit questions. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can. And our first question is, it's a two-part question. What is the percentage of people who have their first manic episode after their 40s Second part, can antidepressive medication initiate manic episodes in monopolar depressive patients?
The first question about how many develop bipolar in their 40s, it's really quite a small proportion. The vast bulk of individuals develop bipolar before the age of 30, most in their late teens or early 20s. The average age of the first manic episode, which is really the defining indicator of bipolar, varies, but most studies it's around 25. Some individuals develop bipolar in their 30s, some in their 40s, but it's hard to for an exact figure, but my reading of the literature for those in their 40s is probably less than 5% are developing bipolar for the first time. The other aspect of this story is that some individuals develop bipolar late in life in their 60s, 70s or 80s, and there's often an underlying neurological or organic cause for that. Can you just repeat the second part of that question for me, Judy?
Can antidepressive medication initiate manic episodes in monopolar depressive patients?
Patients who have monopolar, we probably more commonly use the term unipolar depression, or DSM is major depressive disorder. We know that there is a rate of mania or hypomania developing in individuals without a family history of bipolar. And there's a lot of debate in the field about if you develop a manic or hypomanic episode and you have unipolar, does that mean you really have bipolar? And there's strong arguments on both sides of that discussion. Personally, I'm not convinced that it means someone has bipolar. It's like saying if someone has a fit as a complication of a medication, that means they have an underlying epilepsy. Certainly, though, if someone does develop mania or hypomania on antidepressants, we need to watch that person carefully over time because, in my experience, a small number of those individuals will go on to develop bipolar. But I suppose the short answer is yes, some people do, but it doesn't necessarily mean it's going to be an ongoing bipolar illness. Judy, are there other questions?
Yes. Are there morphological changes in borderline personality?
Repeat that. I missed the beginning of that question.
Dr. Mitchell, I'll repeat that question. Are there morphological changes in borderline personality?
It's a very interesting question. I'm not an expert in borderline personality brain imaging. My understanding is that there are subtle differences. There have been studies comparing individuals with bipolar and borderline showing differences between the two. So the short answer is, and I don't claim to be an expert in that area, is that there are some morphological differences, although these are subtle, but these appear to be different from those that you see in people with bipolar disorder.
Okay, we have time for one more question. I am aware of identical triplets in their early 20s, one who is newly diagnosed bipolar in the Western U.S. They live in the Western U.S. Which study or place of researchers would you recommend for following, testing them in relevant research areas?
Sorry, is the question about which individuals could the family be referred to for further study, or which individuals' publication should I discuss? Can you just clarify, Judy, or it may not be clear?
Well, I would say, okay, so they live in the Western US. They're asking which study or place of researchers, so perhaps a facility recommended for following or testing them in relevant research areas. So I would leave it to you to interpret how you shall answer.
In terms of relevant research groups, there's a strong bipolar research group at Stanford with Terry Ketter, Ketteer. There's also a group with an interest in young people with bipolar in California. I can't remember the institution at this stage, with the main researcher being Kitty Chang. It's a male researcher, Kitty Chang, C-H-A-N-G. So probably those two groups in California, Terry Ketter at Stanford and Kitty Chang in one of the main Californian universities.
I'm going to sneak in another question for you. Can we distinguish between underlying mechanisms in depression and bipolar disorder individuals at risk?
The beginning of that question, Judy, could you repeat that?
Okay, I'll repeat that question for you, Dr. Mitchell. Perhaps it's hard to hear. Can we distinguish between underlying mechanisms in depression and bipolar disorder individuals at risk?
Yes, thank you. I think there's a bit of a delay, an overlap. I think that's a really good question that at the moment we can't answer. I think that's a critical question, and my expectation is that there will be different underlying biology. I think at the moment we're at a very early stage in the science in starting to understand the biology underlying bipolar and unipolar illness. At one level we know that there are differences in the genetics. If you have a family history of bipolar, you have increased risk for both bipolar and depression, so at one level that indicates some overlap. If you have a family history of unipolar, there's a lot of individuals with unipolar, but there's not an increased risk of bipolar in those families. Our own work with people who have depression is that those with bipolar depression don't look the same as those with unipolar depression, which would suggest underlying differences. But I think in terms of what's the underlying biology, we're not at that point of being able to answer that question formally at this stage. My expectation is we will demonstrate some overlaps, but also some profound differences. And I think that's the very exciting research that lies ahead of us.
Unfortunately, we are out of time. I want to thank the audience for their interesting questions and participation in today's event. I would also like to thank Dr. Mitchell for his informative presentation. Today's webcast will be available for on-demand viewing for several months following. You'll receive an email from LabRoots alerting you when this webcast will be available for replay. We invite you to forward that announcement to your colleagues who may have missed today's live event. See you next time. Goodbye.